Allegranzi is joining us online. So thank you very much for taking the time, and especially Dr. Allegranzi, it's all yours.
Thanks a lot, everybody. In particular, thank you so much to the organizers for inviting me. I'm delighted to speak to all of you this afternoon for you about something very important, I believe, in the history of infection prevention and control, which is this new global action plan and monitoring framework that was developed by WHO and countries, member states, and adopted at the World Health Assembly in May 2024. But the topic today is really even more engaging, understanding how guidelines, policies, plans can be translated into country implementation, and especially how these documents can be really instruments, tools that us IPC professionals can use to lever for and advocate for IPC, also in the context of other priorities, and move the agenda forward in your countries and your facilities. So I was saying, so I made a short introduction, and now I wanted to start from setting the scene by reminding us what is the size of the problem that we are fighting. So healthcare-associated infections, according to the European CDC, regarding the European countries and the countries of the European Economic Area, established that healthcare-associated infections bring a burden in terms of premature mortality and also disabilities that is twice the burden of the other 32 infectious diseases that are surveyed and reported by European CDC. And you can see this in this graph where the green bars are HAIs and the other bars are other infectious diseases. And this tells us also about one other point, which is the importance of HAIs in their interlinkage to AMR, because again, if we look at the pathogens that cause HAIs, the burden of the 5 most frequent resistant pathogens is comparable to the combined burden of influenza, tuberculosis, and HIV/AIDS. And these are mostly 4 out of 5 are typically healthcare associated. There are other data that really tell us that most of the burden of AMR is due to infections acquired in healthcare. And so it's important to really connect these two areas, antimicrobial resistance and IPC, but we will see later that this is very much emphasized through the Global Action Plan and Monitoring Framework. If we think about the frequency of HAIs around the world, of course, it's not possible to make meaningful comparisons between countries because often the methodology used is different. But at least in this map, where the data come from one very large systematic review and meta-analysis, from Raofi and others, we can see that at least we can detect that there is a variation according to continents and areas of the world. And also many other studies demonstrated that there is a much higher burden in low-middle income countries than in high-income countries. And this was documented also by WHO in 2010 when we estimated the average prevalence in low middle income countries to be around 15%, whereas for high income countries it was around 7%. And also data regarding incidence, for example, in high-risk areas like neonatal ICUs, tell us that the risk is from 2 to 20 times higher in low middle-income countries. So this is very much an issue which hits the Global South, but also the data from WHO and other institutions tell us that unfortunately there is disparity in the capacity of the low middle income countries to react to this problem in terms of the resources, the programs in place, although over the last few years there have been some improvements. And indeed, over time, we can look at the global picture of evaluation through a system that assesses various dimensions of countries' national action plans to combat AMR, where there is a component related to national IPC programs. And if you look at the graph, basically what we can see with the line across the bars is that over time, since 2018 to 2024, there has been a slow progress, steadily sustained, but this progress is mainly benefiting or brought forward by countries that are already in the most advanced levels in terms of IPC national programs progress. So those countries which were already quite advanced more. But overall, we can also notice that overall 93% of countries report to have an IPC program or plan, but only 44% report to have a dedicated budget, and only 38% of countries are implementing the program nationwide, and these are the two green bars here in the graph. So again, there has been progress, but the issue is always the same: to go from plans to implementation, and also sustain implementation and evaluate the impact of this program overall. Another element which is very problematic and also weakens IPCs remarkably are gaps in WASH, which have been continuously reported by WHO over many years. And for example, what we know is that still in the 2023 report, it was stated that 1 in 4 healthcare facilities lack basic water, or 1 in 2 healthcare facilities lack continuous supplies of hand hygiene at the point of care and toilets. And this situation is even worse in low developed countries. So what can we do? So there are two main axes for our action. One is the intervention and implementation of IPC at the point of care in a people-centered manner and supported by data. And the other aspect is really to invest in convincing and engaging policymakers and politicians, and to generate this political action that is essential to support all our efforts as a national IPC program, but especially at the facility level in all countries. So regarding implementation of IPC at the point of care and developing of programs and practices, as you all know, I believe WHO issued recommendations on the core components for effective IPC programs, and then also some minimum requirements which are critical for at least having a basic level of safety for both patients and health workers, and also a minimum preparation for emergencies, in particular outbreaks. Tackling IPC at the point of care means to really consider IPC as a critical element to achieve quality of care, patient safety, and also to implement all of this across all settings, including primary care. And on the screen and in the slides that you will receive, you can see WHO's tools and guidance on this aspect. The same, it means to integrate IPC within clinical practices in specific risk areas, such as surgery, for example. And again, there is a very wide package of tools that WHO proposes. Embedded also within maternal neonatal, child and adolescent, and also elderly people care. And again, we have a package, especially for maternal and newborn care, that is available from our side. And we are starting now to develop guidance for long-term care facilities. I already talked about the importance of considering the problem of HAIs in the context of combating AMR, but also tackling sepsis, because a high proportion of sepsis cases are due to healthcare-associated infections, and especially the mortality among patients with sepsis due to HAIs in ICU is very high. On average, according to a meta-analysis that WHO did a few years ago, is 54%. So this is really something that we need to highlight the importance of IPC practices in ICU and with critically ill patients. If we now move to the other aspect, the political action, we can start to talk about the Global Action Plan and Monitoring Framework, because we realized a few years ago that not only it was fundamental to develop guidance and help implementation at the point of care, so technical guidelines, but also really elevate the cause and the issue of IPC in the global health agenda. So also learning from the COVID pandemic and the disruptions, and also the harm and suffering that was caused by the fact that IPC was not strongly enough implemented when the pandemic started and rapidly increased in terms of the damage that it was causing. We realized that we really needed more normative documents that countries would give themselves to regulate in the future the implementation of IPC. So a global strategy and also then a global action plan and monitoring framework were developed, decided by member states and adopted, with the aim, with a very ambitious vision, which is by 2030 that everyone accessing or providing healthcare is safe from associated infections. Thanks to the application of IPC best practices across the continuum of the health system, anywhere, any setting where care is delivered, for both for the protection of the patient, but also of the health worker. So this global strategy and global action plan have 8 strategic directions that we need to better develop to strengthen IPC at all levels in each country. First of all, the political commitment and policies. Second, having active IPC programs in place. Third, the importance of integration of IPC and coordination with other highly important priorities in the national health agenda and also locally. increasing IPC knowledge of all health workers and also achieving improvements in the career pathways for IPC professionals. The fifth one is related to IPC monitoring and HAI surveillance, and it's really about having systems in place and using them for action, so having data for action. The sixth is to develop targeted advocacy and communication strategies around IPC and other priorities for which IPC is fundamental. Seventh is to invest in research and development related to the area of work of IPC. And the eighth is to strengthen collaboration and stakeholder support around IPC, but also, as said before, connecting IPC, bridging IPC with other areas of work. So these 8 strategic directions drive the various aspects of the Global Action Plan and Monitoring Framework, because for each of them, we have actions, indicators, and targets at the global, national, and facility level. And I'll try to give you a couple of examples. So for strategic direction 1 at the national level, having political commitment and policies, it means to have a legal framework for IPC to mandate the implementation of IPC programs. It means to have a dedicated budget, also a national action plan and monitoring framework for IPC, integrated or complementary to other national action plans and other aspects. But also strategic direction 2, which talks about having active IPC programs, really emphasizing on the recommendation to have national IPC programs with specific objectives, action plans supported by human resources and budgets, and also these programs to be located at the facility level, having national targets on reducing healthcare-associated infections, and having national guidelines. At the facility level, all of this would translate in commitment and support of the senior managers or senior management, and the allocation of adequate budget, and also having, as I said earlier, IPC programs at least in tertiary and secondary care facilities, and working towards meeting the WHO minimum requirements for IPC. The third area, as I said, is integration and collaborations with a number of other programs, such as quality improvement, patient safety, emergencies, critical care, health worker safety, antimicrobial resistance, WASH, many aspects. And it means to take care from both sides to include IPC principles and standards in other strategies and plans, but also our other way around, having IPC to include other strategies and approaches that are relevant for IPC in their own strategies and documents. And finally, what I mentioned earlier, to have IPC embedded within clinical pathways along with appropriate prescribing of antimicrobial agents. And this expressed in policies, and then at the level of the facility is in SOPs, which really give guidance on how to implement these best practices every day at the point of care. Going to the element of education and training, we really need to have national curricula for IPC professionals, but also for training in pre-graduate courses, also during service, so all health workers, and make this mandatory. So having all health and care workers trained in IPC needs to become mandatory, and for healthcare facilities to achieve the WHO minimum requirements for IPC. There are instruments that WHO recently and also in the past produced, in addition to a package of training courses in OpenWHO, so you can find them on our web pages. And moving to data for action, this means to have national IPC systems for IPC monitoring and also for HAI surveillance and related AMR surveillance, but especially having these systems produce quality data and also the way to use the data, which should be reflected also at the facility level. As I said earlier, we need specific communications addressing different audiences and also campaigning activities to advocate and better communicate about IPC. We need more research, both at the national level, but also have some facilities driving research on IPC, especially regarding the local needs and contexts. For example, adaptation of interventions to the low resource settings, it's an important issue to be researched. And then collaboration, so having collaboration at the global level, but also at the facility level among partners who are all supporting the same cause, which is IPC, and often, unfortunately, do not collaborate among each other. So this is a very important point. Before I conclude, I would like to say that this monitoring framework decided by member states has 8 targets to be achieved by 2030 by all or the majority of countries. And these targets are related to increasing the proportion of countries with a costed and approved national action plan and monitoring framework on IPC, having dedicated budget at the national level, legislation addressing IPC, having an increase of countries meeting all IPC minimum requirements and also improving their level of progress within certain systems such as SPAR, which monitors the IHR, and also the other system that I showed earlier, TRACS, which monitors implementation of national action plans for IPC, for AMR, and also improving the proportion of countries that have basic wash and waste services in all healthcare facilities. Increasing the proportion of countries with a national HAI and related AMR surveillance systems, and also of countries that have a national target on reducing HAIs and they achieve that target. At the facility level, we insist on achieving all the minimum requirements and also having dedicated and sufficient funding for WASH services and activities, which means also infrastructures for IPC. Also, increasing the proportion of facilities having training for all frontline clinical and cleaning staff and managers, and also having HAI and related AMR surveillance systems. These targets aim to achieve and increase the proportion of countries related to those indicators up to 80 or 90% by 2030. These indicators are already included in a number of systems, so it doesn't add to the burden of data collection mostly. And we recognize, of course, that despite of the fact that there was a strong agreement about those targets and indicators among member states and also among IPC national focal points and colleagues from the ground, we recognize that this is quite an ambitious and demanding plan to implement. but we can join forces. WHO is committed to support everyone, but also societies, organizations, I think, should consider really continuously supporting this process over the next decade. And it's important to look also at economic data to make the case for investment in IPC. And notably, according to OECD in their latest report, we heard and we know from them that among various interventions to reduce AMR in healthcare, improving hand hygiene and environmental hygiene, which basically is IPC, is the most cost-effective and cost-saving measure among other interventions to reduce AMR, as I said. So we need to focus on implementation, work together as we are already doing with 12 countries and our colleagues across all levels of WHO, work together to understand what are the best ways to use this policy instrument that is the Global Action Plan for IPC to make a difference at the point of care. So implement it at the country level, at the national level, and then cascading to all levels of the health system at the level of the healthcare facilities, and especially the point of care. It's an ambitious plan, as we discussed, but first of all, we can build upon cost effectiveness data and also effectiveness data because we know IPC is very effective, but also we can build upon many successful examples that we have already documented, including on a WHO webpage that is available for you to consult. We are now having a new list of countries that we are developing stories of, and we will publish very soon. Therefore, I would like to invite you to learn from these examples. Some are quite low-income countries that really did miraculous efforts and also achieved a lot in the field of IPC, and we can follow their inspirational examples. With this, I would like to thank you very much for your attention and again for inviting me, and thank my team, which is behind all this work that I presented today. Thank you.
Thank you, Dr. Allegranzi. It's a great talk. And before I let you go, I must salute WHO for making really awesome contributions to global health. I, as an infectious disease clinician, obviously remember the contribution to reducing child mortality due to diarrheal illnesses by promoting the use of oral rehydration solutions. So we have come back now in 2024. We're still talking about hand cleansing and environmental cleansing, more than 100 years after Florence Nightingale and Ignaz Semmelweis. So I thank you. Would you have one final remark about the challenges of implementation, particularly in low and middle income countries? And since we are talking about the global South, for the global South. Thank you.
Yes, certainly. First of all, I would like to point you all to the 2022 Global Report on IPC, where we highlighted challenges and also solutions. So given that we don't have a lot of time now, you can find this information in that report. And also I'm happy to announce that in November, we will issue the 2024 edition of the Global Report, where again, you will find new data and also mention to challenges and solutions. The thing I would like to say is that, as I said, in many studies and also from local evidence, we know that IPC is often low cost. For example, hand hygiene among a number of interventions to reduce AMR has been estimated as the lowest cost intervention. And the issue is, in my view, in terms of overcoming the challenges for implementation in low resource settings, I think the issue is to find low-cost solutions and be aware that the problem is, at the end, always behavior. So behavioral change and convincing health workers that implementing IPC best practices is necessary for their safety and especially for the safety of patients, and that they can save lives by doing this. So we need to really dedicate more investment and energies on building a culture of safety and also a culture of pride to be implementers of IPC best practices. This is something that can be done anywhere without major resources, but it's something that helps maintain also this climate of safety, which motivates our frontline health workers every day when they come to work. In any case, given that we don't have time, I would like again to address you to a number of WHO publications on also challenges and solutions in low resource settings. We have also important publications in the scientific literature. You can find all of this in this 2022 global report I mentioned.
Thank you, Dr. Allegranzi. And once again, thank you very much. We appreciate you taking the time off to join us in this conference. Thank you very much.